Welcome to Dermacoaching. In a case discussion series, today we will be discussing about LIGA, which is the linear IGA disorder. Let us start with the history. So, a 35-year-old male presented to the OPD with complaints of intensely itchy or intensely pruritic fluid-filled lesions. These lesions were present on the body for the past 7 to 8 months. So there were periods of aggravation, there were periods of remissions, and the current aggravation or the current exacerbation was present for the past 2 to 3 weeks. Lesions were intensely pruritic in nature and they were associated with burning sensation. First, itching used to develop, and this used to be followed by the development of fluid-filled lesions on the body. Some of the lesions they used to settle down on their own, but the lesions did not rupture on their own. They used to settle down, but the history of rupturing, leaving behind raw erosions, painful erosions, that was not given by the patient. Before this current aggravation, patient gave a history of URI, that is the upper respiratory tract infection, around 2 weeks before the development of this particular aggravation or this particular episode. Otherwise, no other history of recent trauma or drug intake was given by the patient. So what is the positive history? Positive history is presence of fluid-filled lesions on and off for the past 7 to 8 months, and the current aggravation was present for the past 2 to 3 weeks. They were intensely pruritic and associated with burning sensation, and the current aggravation happened after a recent episode of URI. What did I see on examination? On examination, I found multiple tens, vesicle and bullae, which were arranged annularly over erythematous and urticarial plugs over the neck, the trunk, and the flexural area. So let us repeat the positive findings. Multiple tens, bullae, arranged annularly over erythematous and urticarial plugs, predominantly over the neck, trunk, and the armpits. If we look closely at the arrangement of these vesicles in bullae, they gave it a string of pearl appearance. So you can see that they are arranged annularly, giving it a string of pearl appearance. This is the classical appearance of LIGA, which is the adult variant of CBDC. CBDC, it is seen in childhood. It is the IGA disorder which is seen in the childhood age group, but the adult variant is LIGA. If we talk about this classical string of pearl appearance, it is more commonly found in the childhood age group. It might or might not be seen in the adult age group. Here I was lucky enough to see the classical string of pearl appearance. What about the other side? The palms and soles, the oral cavity, and the scalp, it was not involved. The pulse shape was not negative. After seeing this kind of picture, few DDs come in mind automatically. Usually, whenever we see a tense bulla over an erythematous and urticarial veins with a history of itching and burning sensation, the first diagnosis that comes to our mind is bullous pemphigoid. But here, because of the classical string of pearl appearance, the way these vesicles and bullae they are arranged, it gives the indication that this is probably LIGA and not just simply bullous pemphigoid. So here the predominant autoantibody which is deposited, that is IGA rather than IgG. Okay. So these three were the predominant DDs in my mind. Obviously, LIGA, which is the linear IGA disorder, and BB, which is the bullous pemphigoid. Just to complete the list of DDs, impetigo was also, covered by me because long time back I saw a similar case in childhood age group, obviously, and it turned out to be impetigo. The DIF was negative, and the histopathological changes were more in favor of impetigo rather than the CBDC. I know impetigo is not seen in this age group, but just to complete the list of DDs, impetigo was also considered by me. Coming to the management part. Now, when these DBs came to my mind, I need to confirm the diagnosis. So I had to do a battery of tests. First, the routine investigation. So there are two types of tests. Whenever a case like this comes to us, we need to prove it by diagnosis, and then we are supposed to do certain tests so that we are able to start the patient on the required drugs. So two types of tests are done: first for confirmation, and second to start the patient on certain drugs. For confirmation of the disease, histopathological examination and DIF was done after taking the biopsy of the patient, and to start the patient on certain drugs, I got the routine investigation done. The routine investigations included CBC, LFT, KFT, and chest X-ray, PA view, the normal sugar, the fasting blood sugar, BP monitoring, blood pressure monitoring, and Montu test was done. And obviously, urine routine examination was also done. G6PD was also done in this particular patient. So these were the normal tests that were done. Now let us talk about the specific test to prove the diagnosis. As I have already mentioned, to prove my diagnosis, I took biopsy for histopathological examination and direct immunofluorescence test. What did I get in histopathological examination? Let us look at the keywords. Subepidermal blistering dermatitis with numerous neutrophils within the blister cavity. Now this thing is very important. Neutrophils. Why? Because subepidermal blistering will also be seen in bullous pemphigoid. But over there, the predominant cell which is seen is eosinophil rather than neutrophils. And in LIGA, that is the linear IGA disorder, neutrophils are the predominant cells which are seen. What was the other thing that was seen? Blister roofs showed mild spongiosis. The periphery of the blister showed mild spongiosis along with collection of neutrophils. Neutrophils were also seen in the papillary dermis. What about the floor of the blister? Interstitial infiltrate of the neutrophils and eosinophil. So this subepidermal blister was consistent with linear IGA disorder. I'll repeat the main findings with the help of the picture of the slide. So if you look at this particular slide, this is in lower magnification. There is definitely a subepidermal blister. This is the epidermis, and just below the epidermis is the blister. That means the blister is subepidermal in nature, and there is collection of certain cells. Here we are not able to see very clearly what is the nature of cells, whether these are neutrophils or eosinophils, but in this particular blister cavity we see there are various multi-lobed cells. So what are these multi-lobed cells? These are definitely the neutrophils. I'm sure you know from your basic histopathology knowledge that the neutrophils, they are multi-lobed or tri-lobed in nature, while the eosinophils, they are bilobed or spectacle shaped. Now here maximum cells that I can see, they are having 3 lobes, and this is having actually more lobes. So this is a multi-lobed cell, which is obviously the neutrophil. Let us look the same slide in under a higher magnification. So here the blister cavity is beautifully seen, and now there is no doubt that it is a subepidermal blistering disorder. If we look at the cells, here can you see the 3 lobes? Okay, here a multi-lobed cell, again a multi-lobed cell. So these cells are mostly neutrophils. So neutrophils, they are present in the blister cavity. They are also seen in the floor of the blister, and they are also seen in the dermis. So the features were more consistent with that of linear IGA disorder. What about DIF? What did I see in DIF? I'm really sorry I could not get the colored picture of the same. But anyhow, let us go through the findings that we got in the DIF. So there was linear IGA deposition, 3 plus linear IGA deposition at the dermoepidermal junction. What about IgG? IgG was also positive, 2 plus linear IgG deposition at the dermoepidermal junction. Even though the picture is black and white in nature, you can see that there is some kind of immunofluorescence basically which is present, and this is IgA. Look at these terms: linear deposition, predominantly of IgA followed by IgG. In the last case, when we were discussing about dermatitis herpetiformis, the deposition of the IGA was not at all linear. It was granular deposition in the papillary dermis, and that is how it is different from dermatitis herpetiformis. First of all, the clinical features are totally different. And if we talk about DIF, here the deposition of IGA, it is linear and it is present at the dermoepidermal junction. Okay. So both the histopathological examination and DIF, they were consistent with linear immune deposit, which indicated that this was linear IgA disease. Now let us learn about linear IgA disease in short. What it is actually? It is a subepidermal blistering disorder. It is an autoimmune disorder where mostly IgA autoantibodies, although IgG can also be seen, but mostly IgA autoantibodies are seen against PP180 and its shed ectoderm, can be also seen against PP230 and LAD285. So these are the antigens against which the autoantibodies are formed, which are mostly IgA in nature. If we talk about the induced cases of linear IgA disorder or the associated diseases, so it can be induced after certain infections. So in this particular patient, there was a recent history of URI prior to this particular episode of aggravation. And it can be also seen after certain drugs such as antibiotics like penicillins, vancomycin. It can be also seen after the consumption of diclofenac or NSAIDs. Can be caused after a local skin trauma. It can be associated with ulcerative colitis, then certain malignancies as well, such as bladder and renal carcinoma and other lymphoproliferative disorders. One thing that I would like to stress about in this particular case is that in such cases, it is always beneficial to do direct immunofluorescence along with the normal histopathological examination. Why? Because such cases are very similar to bullous pemphigoid, and in bullous pemphigoid, mostly eosinophils are seen. In linear IgA, mostly neutrophils are seen, but sometimes both neutrophils and eosinophils are seen, which makes it kind of difficult to come to a proper diagnosis whether it is linear IgA disorder or whether it is bullous pemphigoid. And that is where DIF comes into play, which shows exactly what kind of autoantibodies are deposited where and what is the pattern of deposition. That is why DIF is a must for autoimmune bullous disorders. So that is my class for today. Just a small revision of how does LIGA looks like. So this is the classical finger of pearl appearance where multiple tense bullae and vesicles arranged annularly over urticarial or erythematous flaps are seen, which gives it a string of pearl appearance. And here, how did I come to the diagnosis finally? After doing the histopathological examination and the DIF, where in histopathological examination, a lot of neutrophils were seen in the blister cavity. The blister cavity was subepidermal in nature. And in the DIF, IgA and also IgG, linear deposition of IgA and IgG was seen at the dermoepidermal junction, and that is how I came to the diagnosis of linear IgA disorder. I really hope you liked today's case discussion series as well. Take care. Have a nice day.